role of DARE in total joint arthroplasty. So the problem of infection is real. Acute infection after hip replacement is between 0.3 to 2.9%. But in recent years, there's been about a 500% increase in the number of infections. And the optimal treatment for acute PJI is unknown. The major determinant, or what scares us, is whether biofilm has formed and DARE is going to work in these patients or it's not. So what is acute? What's the definition of acute? Depending on which paper you read, the duration of acute from the time of index arthroplasty varies. During the last ICM, it was discussed that having a binary division between acute and chronic, with the use of things like 4 weeks is the cutoff, is probably not very wise. Biofilm formation is a continuum, and because of that, it's probably most important that we should be thinking about other critical factors, in particular, the biofilm itself. So how long does it take for biofilm to form? It depends on a lot of factors: size of inoculum, mechanism of colonization, virulence of the organism, the host itself, whether there have been other factors or not. So the question is, should you do DARE for acute PJI? The failure rate that's been reported is anywhere from 30 to 80%, and depending on which paper you read, a failed DARE could potentially compromise the outcome of a definitive procedure like a 1-stage or 2-stage later. So because of that, the consensus recommended that we should be focusing on host factors, operative factors, and organism factors, and not just stick to one time point from index arthroplasty. And that's based on numerous publications that we have seen. Now, what's interesting is that DARE for acute hematogenous infections usually doesn't have as good of a result, and there's a current thinking that acute hematogenous is perhaps an acute on chronic infection. These patients probably had some form of bioburden, and then a second hit comes along, and then they get infected, or they manifest it in the form of acute infection. So at this point, we're not quite sure what the exact factors that affect the outcome of DARE, but certainly host-related factors have been studied and seem to be very important. Patients who have comorbidities are certainly at a higher risk. The presentation of infection itself is very important. The number of white cell count, for example, could influence the outcome. And then other parameters, such as the organism profile, whether it's resistant, gram-negative, or fungi. Time from index arthroplasty is one of those factors, and interestingly, not the most critical factor at all. You've seen the comorbidity profiling that we've seen from CRIME 80 and CLIC, and these again put emphasis on the importance of patient optimization. So prior to DARE, we should certainly try to optimize these patients as much as possible, particularly hyperglycemia and diabetes. So, does DARE work? Who should you offer DARE to? That's why we did this in artificial intelligence algorithm. We used patients from 65 different institutions across 14 countries, and we looked at 286 different variables. The result of that was published previously. I'm going to share with you what we found that was most important. There were 10 factors that influenced the outcome very much, and these are on this list, as you can see, including the presentation and how inflammatory the patient was at the time. Interestingly, how you did DARE, whether you changed the modular components or you didn't, also influenced the outcome. That's been cross-validated currently. It's available as an app. It will most likely get updated next year in the consensus meeting again. But if you put any of those variables, it will give you an idea as to what the expected outcome of a DARE is going to be. So on the DARE side, the most important factor is the surgical technique itself. This is George Ciarnine, And George Tierney always used to say, treat infection like you're treating cancer. You should get clear margins, and you have to do extensive synovectomy and debride and remove. You must take cultures from various areas, 5 of them. You must irrigate, and irrigation that we use is based on what the consensus has recommended, 4 different types. I also double drape and change the drapes at the end. Antibiotics. Should you give antibiotics to your patient or not after surgery, and if so, how long? There are studies coming out showing that longer the antibiotic, the lower the risk of failure. I personally think that's a bias. You're kicking down the failure to another period. At this point, the most important paper that I have seen is the one from France that showed 12 weeks of antibiotics provided the best outcome. This is a question for next year's international consensus. I personally think 12 weeks is probably the most optimal following surgery. And the signal is very strong. You give 6 weeks, the failure is higher. You give 6 months, makes no difference. So 12 weeks seems to be the best period at this point. How about identification of a pathogen? Should you try to identify the pathogen before you do DARE? That was a question that was asked, and the answer is it probably does not matter. You should optimize the patient and take the patient to the OR. Finally, hips that are uncemented, presenting with an infection in the early days after index arthroplasty, in my opinion, are best treated by one-stage exchange. Remove everything, debride, irrigate, put new components. And as you can see, this was the finding of that particular study that we published. But again, most of these questions that I just presented to you are going to be discussed next year in the consensus, and hopefully we will have better responses and results for some of these questions that we are unable to answer today. Thank you.